Welcome back. In the last lesson, we went through a little literature history about what we used to think about occlusion and muscle activity levels in bruxism, and then some more current literature. Now we're going to step into an even more current world, and we're going to talk about attrition, bruxism, and apnea. And, for years, I think we knew that there was some central nervous system link between some of the occlusal behaviors we saw, but we didn't necessarily have an idea of what the link was or what the trigger was. And so I'm going to start again with a little bit of literature, and then we're going to kind of walk through it and move into an even more current piece. So in 2008, Gilles Levine, who's from Montreal, is a great researcher on sleep, in particular apnea and hypopnea. And he wrote this paper for clinicians, specifically about bruxism. And the title was Bruxism, the Physiology and Pathology, an Overview for Clinicians. And here's what he said. Basically, awake bruxism is defined as awareness of jaw clenching or grinding during the day. The prevalence of awake grinding is about 20% in adults, about 1 in 5. The physiology and pathology of awake bruxism at that time wasn't known. I will tell you today there's some evidence that in fact daytime grinding significantly reduces cortisol levels, and cortisol is your stress hormone. So today there is much more of a belief that in fact people may be grinding their teeth during the day as a way of managing stress. And even back in 2008, he did say that stress and anxiety were definite risk factors for daytime bruxism. Bruxism, nocturnal bruxism, if you average the population age, is about 8% of the population, he said. 2008, sleep bruxism was classified as a sleep-related movement disorder similar to restless leg syndrome, and that there's very limited evidence in the literature to support that the occlusion was a causative factor in nocturnal bruxism. Current research, 2008 paper, current research was that sleep bruxism was secondary to what was called a sleep-related microarousal. And the microarousal isn't you waking up, it's an increase in your sympathetic nervous system activity. So your heart rate, your respiratory goes up, happens in some patients 8 to 14 times an hour, and the people that they had studies, those were average numbers. And what's called an RMMA, which stands for rhythmic masticatory muscle activity. In fact, the microarousal then leads to this RMMA where the opening muscles and the elevator muscles start contracting, and that happens prior to the person grinding their teeth. So if you were to look at, quote, a bruxism episode from this paper in 2008, you would have something that triggered the microarousal, and that's something that the paper was talking about was apnea or hypopnea, so a desaturation. They also wrote about back then gastric reflux being a potential microarousal agent. Following the microarousal, your heart rate goes up, your brain activity increases, and then your muscles get involved, but guess what? Your teeth aren't touching yet. So all of this happens, and it can happen for a few minutes before the person actually bruxes. So that's sort of a new way back in 2008, a new way of thinking about why people bruxed, is that there was an entirely different thought process than, oh, let's get rid of the occlusal interferences, then they'll stop grinding their teeth. It's like, wait a minute, maybe they're grinding their teeth because in fact there's this central nervous system, and maybe in fact what apnea is doing is it's triggering the body to brux as a way of opening airways and getting oxygen saturation back in. Do we have evidence that in fact managing apnea or hypopnea reduces bruxism? For sure, we do. You have papers like this one, the patient who was put on a CPAP. He was in a sleep laboratory prior to CPAP. He was diagnosed with both obstructive apnea and bruxism. He had basically about 67 grinding events per night on average while he was in the sleep study. They occurred after an apnea-hypopnea event. So he had an apneic event or a hypopneic event, his oxygen saturation went down, and following that, there was 67 events of grinding. They put him on a CPAP machine back in the sleep study. The CPAP eliminated most of his breathing episodes, but it eliminated all of his bruxism. And so there's no question that we do have evidence that, in fact, in some patients, airway issues are, in fact, most likely an etiology for some patients' bruxism. Do we have more evidence than that? Apneic appliances, we do. You start looking at the reduction of sleep bruxism using a mandibular advancement device. And again, this is another one of Levine's papers. And if you look at using that apneic appliance in patients that are diagnosed with apnea and brux, so this is 13 intense bruxers, they wore full coverage maxillary appliances, and when in a sleep laboratory, they had apneic appliances when in the sleep laboratory. And their apneic appliances, they actually set them 3 different ways. They let the patient move around where they didn't hold the mandible forward. They advanced the mandible 40%, and then they advanced the mandible 75%. And again, they went through the sleep study. Interestingly enough, the full coverage appliance actually did reduce bruxism, almost 42%. The apneic appliance, the mandibular advancement device, did better at about 60%. And so, yes, we show that, in fact, when you change airway, there is an alteration in terms of bruxism. So you would start to basically assume that apneas and hypopneas are, in fact, the trigger for bruxism. The question is it the only trigger for bruxism? So now you go and you look at a paper that takes an anterior bite plane, in this case an NTI, and you look at a group of people who have been diagnosed, 10 patients diagnosed with sleep bruxism, and you put them on an NTI, and then you also have them wear a flat plane full coverage. You put them in a sleep laboratory over a 2-week period, switching between the appliances, and lo and behold, the sleep bruxing episodes went from 19 an hour to 9 an hour with the NTI. They cut it in half, but only 16 an hour with flat plane. Flat plane didn't reduce the bruxism much at all. And so what happens is in dentistry, we've started to think, because of our awareness of airway and our awareness of apnea, that the way we solve a lot of these patients' issues is to hold the mandible forward. But an NTI doesn't do that. And you start recognizing that, in fact, it may not be the need to hold the mandible forward. It may be, in fact, that in some patients, simply opening the vertical and giving their tongue more room is what it takes to open the airway. It's why Jeff Rouse and Greg Kinzer here at Spear created their Seattle protocol, recognizing that when we move all the way to an apneic appliance where we hold somebody forward, we potentially introduce a lot of side effects. And if we can, in fact, solve the patient's symptoms without going to that extreme, we can minimize the side effects. One of the parts of that protocol is to, in fact, open the bite but not pull the mandible forward. But for sure, it looks like there's definitely a link between airway and bruxism in the world we live in today. What are some of the other beliefs I had from the past? That patients applied the greatest force to their teeth when, in fact, they were sleeping and bruxing at night. That all the damage was happening at night, and therefore a night guard would save you. And so for all of my patients that had tooth wear, going way back to the late 70s and into the 80s, everybody got a night guard because I assumed that would be safe. And just as a little fun kind of side effect, just because we talk about bite force a lot, the species that actually has the greatest bite force ever measured is actually a crocodile. You can use that some night at a party with your friends. They probably don't have the greatest bite force there is. It's just that you can safely measure a crocodile's bite force. You probably can't do some of the other animals' bite force measurements. This study in particular, though, is interesting because it measured the variation in bite force between sleeping and bruxing versus daytime muscle activity. And so what they did is they took 10 subjects, they measured their maximum daytime clenching force, and then they recorded their bite force during bruxism at night. Their average bite force at night during bruxism was 22.5 kilograms a foot. The highest bite force measured at night during bruxism was 42, but the mean measured daytime clenching was actually 79. And so what we're starting to learn is, in fact, that daytime clenching and grinding may be far more damaging to teeth than we ever dreamed it was. And in fact, that may be where a lot of our patients are doing so much damage. You can certainly wear out your teeth at night for sure. So an appliance in somebody that has a nocturnal bruxing habit definitely protects teeth, but the bite forces applied are typically about half or less of what a person can apply during the day. And it varies. One person in this study actually did have more bite force when they were bruxing at night than when they were clenching during the day. But most people are significantly lower when they're sleeping and bruxing. Their bite force is significantly lower than what happens when they clench and grind during the daytime. And just to kind of bring all that home with you, this is a patient I treated in 1985. Massive tooth wear. We're going to put some implants in the lower right and lower left. We're going to restore her teeth. There she is before and after. I immediately make her a night guard. I mean, she gets my night guard within a few days of the restorations being completed. And you can see the difference between the before and after, the implants on the lower right. What I want you to look at is she basically was end to end, had a very flat, almost no guidance in the front before from tooth wear. And I was in my nathology phase of life, so I seated her condyles and I gave her an anterior guidance that related to the steepness of the eminences in back. This is what she did to it in 8 weeks. Broke the lateral, broke the central. She'd been wearing the night guard every night. She broke them during the day. I cut the lateral off, new final impression, put it in, adjusted it. She broke it again within 2 to 3 months. I cut it off, new impression, third lateral. I shortened it so she couldn't hit it. That worked. She took away the cuspid. That broke. Cut the cuspid off, reimpressed it, new crown, shallowed that out a bit. She took out both central incisors. Over the course of 18 months, she broke every single maxillary restoration a minimum of 1 time, sometimes 2 and 3 times. What was the problem? Number one, I wasn't protecting her teeth during the day because she was only wearing the night guard at night. But the big problem was, in fact, this is a patient where classic anterior guidance doesn't work for her. It's too steep. She needs a very shallow guidance pattern. Finally, in about early 1987, after she'd broken everything so many times, I told her I really wanted to shorten the upper teeth to try and get them out of the way. So these photos have been sized the same, so the width of the 2 centrals is the same. And I'll draw an arrow on the one on the left, which has been shortened, and I'll take that arrow and move it over onto the one that hasn't been shortened. And you can see I shortened her teeth almost 2 millimeters. What's amazing is after I shortened her teeth almost 2 millimeters, she called me the next day when she woke up in the morning and took her night guard out. And she said to me, you know, I've hated these teeth for 18 months until today. I took my night guard out this morning and they feel like my teeth because they're not in the way. And so a couple takeaways, this patient's grinding during the day and she's grinding with massive force. What do we do when we have patients that grind during the day? We try and get the teeth out of the way. That often means really shallow guidance. It often means actually group function on everything. And I mentioned earlier, what do we know about daytime grinding? We know, in fact, that if you look at research on it, if you take 17 subjects, they intentionally stress them by having them do arithmetic exercises over 20 minutes, and then they measured their salivary cortisol level to see how high it was. Then they gave them 10 minutes to read and chew wax, like chewing gum, only chew wax. They remeasured salivary cortisol levels, and chewing the wax dramatically reduced their salivary cortisol level, again, evidence of the stress hormone. They then did it another day where they stressed them again. only this time they had them go out on their front teeth and clench lightly on their anterior teeth 10 minutes after their initial stress test. Clenching on the anterior teeth reduced salivary cortisol just like chewing gum or chewing wax did. And so we're getting a better understanding of what's leading to some of these things that we've really not been able to understand in dentistry, like that patient I just showed you. I mean, I was completely confounded by the fact that she was breaking everything at first, and I thought I had done everything perfectly in 1985, and I had made her that night guard, and yet she destroyed everything until, in fact, I finally got the occlusion corrected for what she was doing. So I hope that this lesson helps you start thinking about, yes, we have evidence that apnea appears to be responsible, apneas and hypopneas, for some patients' bruxism. In upcoming lessons, we're going to talk about the fact that it's not the answer for everybody's bruxism. Thank you.